Good afternoon, everyone. We're given the green light to get started. I hope that sorry to interrupt some of those conversations, but today we'll be discussing understanding your patient population in order to build an appropriate patient engagement strategy as a introduction for, there we go. So I'll let Brad introduce himself first, and then we'll jump into the presentation.
All right, welcome. My name is Brad Meyer. I'm the CEO for Bluestem Health in Lincoln, Nebraska. We're a federally qualified health center. This year, we're slated to have about 21,000 lives. And out of those lives, about 60% of them are in a value-based care contract. So we have over 12,000 patients that are in some type of value-based contract. So I'm going to talk a little bit about why we ended up doing those, including one full risk contract. And if you guys have never heard of a full risk, you should have just a little bit of a pucker factor when you hear that word, because it can be really good or it can be really bad, but we'll talk about that in a little bit. So.
Fantastic, and I'm honored to have Brad join me. My name is Michael Dudley. I'm the Director of Physician Development here at Good in Health. Bluestem is one of our partners. We'll be talking, I've spoken on value-based care and population health a number of times this year. We'll be really shaping the conversation that I traditionally do, but really honing in on patient engagement and kind of extending what that really means. And so we'll kind of have a little exercise here at the very beginning. I do want to make a disclaimer that I do work for an organization that provides chronic care management services. So later in the presentation, I'll be showing some data. So I just want to be transparent with you guys that I'll be showing that. As an agenda, we'll be talking about where is healthcare today? What is value-based care? What does value-based care look like here in Nebraska? How do population health principles drive patient engagement priorities? And then finally, what practical steps can you guys take to be able to build a patient engagement program to properly prepare for transition to value-based care? So you hear a lot of value-based care, so you might be wondering what's the tie-in with patient engagement? So we'll get into that as well. But I think before we get started, I think it's important to mention where we are. As you know, and I'll breeze through this because you guys are probably very familiar with this, and specifically that the healthcare system in the way of cost is broken. We're about $5 trillion in healthcare costs, about 20% of GDP. If you kind of want to put one word on healthcare today, it's unsustainable in a fee-for-service market. But you're saying to yourself, well, we must be receiving better care, right? And that's not necessarily the case. We rank 26 out of 35 countries, well-established countries, when it comes to healthcare and life expectancy specifically. And then obviously when it comes to those costs and what those look like, there's some usual suspects, things like diabetes, hypertension, COPD, and I won't get into all of this data. I think you guys get the point. You guys see it every day. But these will continue to grow. We have about 66% of patients have multiple chronic illnesses, and about 1.5 million patients will age into Medicare in just the next few years. And then on top of that, we have a physician shortage. You guys know that. Finding staffing is one of the hottest topics in healthcare today. So we'll kind of discuss, is value-based care the answer to fix all of healthcare's problems? And I'll be the first to announce that there's no silver bullet. Even value-based care, as great as it is, cannot necessarily in one foul swoop solve healthcare. But when it comes to CMS and what they believe, and honestly, a lot of us here and the independent practice healthcare system side of things, we have to follow the money to a certain extent and kind of follow what CMS wants us to do. So Liz Fowler, the director of CMMI, mentioned this in mid-pandemic. So you're thinking to yourselves, so many healthcare priorities at the time, what's she going to say? And she says, I want to make it clear that our commitment to value-based care has never been stronger. And a lot of when we look back at the timeline of how healthcare has evolved, you can kind of see that this is the way that they're incentivizing us, the way that they're pushing us when it comes to PQRS, moving to meaningful use, and now MIPS and MACRA. Even if you look at MIPS, it essentially was created to be an on-ramp into advanced alternative payment model. So value-based care is here to stay, and it's going to happen. I can't emphasize this much. I can't emphasize this much more, and I don't want to be overly dramatic, but this is not just a binary. You can't just move from fee-for-service to value-based care to full risk, the program that Brad was talking about. It is a spectrum. I almost want to paint the picture that this is almost like a stair step. You do kind of have to get your feet wet in a little bit of Medicare and shared savings before you move into some type of downside risk. But this is something that you want to start to keep in the back of your mind. Now, you're probably wondering what I was mentioning earlier. I thought something was about patient engagement, right? Well, when you think about our engagement with patients, this is what has caused fee for service, right? The patients come to us, regardless of what specialty, primary care, et cetera. They're going to come to us when they think that they need the services, and we're going to provide the services, and then they go back into whatever type of lifestyle that they were in. This is fee for service, and this is unfortunately what's caused a lot of those costs to go up. But as we move up these steps, there's a lot more that you kind of can tie in with that. It's probably a small print, but it says manage a population on the bottom right. And that's really where we'll spend the majority of our time talking about what does it mean to manage a population? What does it mean to be engaged with our population? And again, I don't want to be too over dramatic, but this is, you do have to move up these steps. I kind of want to paint the picture that if you do not move up these steps, your practice could be underwater. It could drown. And I do think this is really important. And this is one of my missions is just to be able to get practices familiar with it, get stories like Brad's out there that this is happening and it's okay. You guys can do it, but it does take leaning on resources such as the MGMA, all the great partners that are in the next room to be able to move into that. So again, manage a population is the key here. But you see, as you move up these steps, you see your shared savings, you see your shared risk, you see even this global payment capitation. I know many of you are thinking, well, hey, that's capitation, value-based care. That's really for the soup guys in Florida or Texas or California. This is Nebraska. What's Nebraska doing with value-based care? And I think Brad's the perfect example. So I'll let him describe a little bit about some of the programs he's in from Blue Cross Blue Shield to the very innovative stuff he's doing with Medicaid, Nebraska Total Care.
So one of the things that we've noticed, and you guys have all probably noticed this too, is that we are attracting patients. Year over year, we have an increase in patients, but our encounters per patient are going down. And so we've seen this over the last 5 years. And so what we are trying to do is try to figure out, okay, our patient service revenue is declining. What can we do to offset those losses? Value-based care was kind of being thrown around. And so we went to a couple of our payers and said, are you interested in a value-based contract? And when we first started, it was all upside. So we didn't have any risk in it at all. And we did well. In fact, we did so well that federally qualified health centers, there's about 1,400 in the United States. When I first started 8 years ago, September 2014, our organization was ranked 868 out of 1,400 federally qualified health centers. In 2021 or 2020, we were ranked 36 out of 1,375 federally qualified health centers. And last year, we just got our numbers and we're ranked 56. So we're still in the top 5% of our health outcomes. So we know that we provide good care for our patients. And so we went back to our payers and said, okay, let's start looking at these value-based contracts because we all have a lot of data, right? We have so much data, we don't know what to do with it. But when you start looking at value-based care, you're getting now claims data. So you can see what each patient costs you every month. And so when you start looking at your highest risk patients, you start to figure out, okay, now what are our most expensive patients? Those are going to be renal disease, they're going to be cancer, they're going to be some type of other terminal illness. And then as you get down, you start looking at hyperlipidemia. You know what I'm talking about. Diabetes, CHF. And so then you're like going, okay, well, those are things that we can start looking at. And we just started looking at all kinds of ideas, and we failed a lot. I could give you a 2-hour presentation on all the failures that we had. We learned a lot in future contracts. And so one of the things that we do, so we have medical, dental, and behavioral health. One of the things that we were noticing on, and nobody pays attention, you guys probably, some of you guys may know this, but who cares about dental patients, right? Unless you're a dental practice. But if you have claims data showing that your patients are going to the ER for abscesses and you are in a full risk contract, that medical insurance is paying for those visits, not the dental insurance. So with us, so we have patients in United Healthcare, Nebraska Total Care, and Anthem ACO arrangements. We also have Blue Cross Blue Shield ACO with One Health. Some of you guys are One Health members. And then our newest is we are in a Medicare shared savings plan with Caravan Health, now Signify Health. And so essentially a lot of our patients are in some type of system, and the data that we're getting back has been great. And so dental really threw us for a loop because we didn't really catch that. But when we started looking at the claims data, a lot of the ER visits are for tooth pain. And the doctors, the ER doctors, are not dentists. They want to give you an antibiotic, they want to give you a pain pill, and they want to send you back to your PCP or your dentist. Well, once you give a mouth sore patient antibiotic and pain pills, what happens? They get better. So they never follow up with their dentist until 3 or 4 or 5 weeks later, that tooth comes back. And so we actually stopped seeing commercial insurance patients in our health center because we had so many Medicaid patients, so many Medicare patients that were going to the ER that the commercial patients were taking up space. Any commercial patient can go to any dentist's office and get dental care. Our job is to focus on those that have a barrier, some type of barrier. And so we got rid of our commercial insured. We're not accepting any new ones. And that opened up slots for those patients. And so Brian and St. E's now say you don't have insurance or you don't have a dentist, go see Bluestem Health. We have to triage those, of course. And so we're usually pretty good at getting them in for emergencies. So we do a lot of extractions, just FYI. Everybody wants an extraction. They just want it taken care of. But if we can save the tooth, we try to get them to come back, but our waiting times are 3, 6, 9 months sometimes. And so when you look at value-based care, you're looking at the whole patient. It's a holistic approach to medicine. And so you're treating the mind, body, and spirit, and that's how we've kind of taken the first steps in looking at the data. And then we found out that there's all kinds of other things going on with our patients. We have patients that, everybody knows that patient's Dr. Hop. But when we see the claims data, we can now get those patients to come back to us because we call them up. And we know that which pharmacies they're using, even though you can use the PDMP. How many of your providers use that religiously? You would hope so, right? But the PDMP is good. It's a good tool, but it's not great, and it takes time, and the providers we found do not check those as often. So having that claims data helps our providers identify those patients. And so far, we've seen about $1 million, I said, in loss of patient revenue, but our value-based contracts, we're a $23 million organization. We are going to clear about $2 million from 2021's outcomes. So that's over 10% of our annual revenue is in value-based care. So that's more than making up for those patient service revenues. And what are we doing with that money? We've got 3 certified diabetic educators. 2 of them are nutritionists, registered nutritionists. None of our patients have to pay anything to see those CDEs. We have a paramedic that is a liaison between the hospital systems and our entity, our providers. So if Brian is discharging one of our patients and they're like, well, this patient is a fall risk, that paramedic will go out there and she will either take away the rugs or she'll put glue sticks down or glue trap. Not glue trap. You know what I'm trying to say. English is my first language, believe it or not. But she goes out there and she makes the patient's house safe. She also goes, and again, we don't charge for her services, but she goes out there if Dr. Israel, our chief medical officer, if he's laying in bed one night and says, Sally Ann has bipolar, she hasn't been in for a while, he can send Jane out there, and Jane can have a conversation, 20, 30, 40 minutes, and report back to Dr. Israel and say, yeah, Jane's doing fine, her house is safe, she's got fruits and vegetables, and everything seems to be going fine. Or when Sally Ann answered the door, she's wearing a tinfoil hat and all of her windows were boarded over. So that helps Dr. Israel determine whether or not that patient needs to see our behavioral health specialists or whether he needs to get them back in. So we're using that additional revenue to provide services that we would not have been able to do before. And that is all holistic approach to medicine. And so we are looking at just taking care of the whole patient. Some of your patients don't need anything. Some are more complex. And so that's kind of what we're doing with value-based care. And I know we're on a time crunch, so I will.
You mind if I jump in for a second?
Yeah, go ahead.
So we're next going to hear a little bit about what he's doing specifically with the Medicaid total care. But I think from talking with so many great people today, there's a lot of specialists that, I've talked with an ENT, talking with an eye group. But so I think everyone's wondering, where do I fit into this value-based care? And I think, Brad hit the nail on the head, which is just that everyone's going, the primary care practices that your patients will see traditionally, they're going to be thrust into this. And so I think it's really important to think, how do we fit in with this? How do we reach out to the federally qualified health centers, the private practices, and try to get involved here? Because there will be a point where they're going to be thrust to make a decision, maybe sell to the hospital or do something else, and it's going to throw your practice and your specialty into a unique position. So thank you. I just wanted to interject there because I saw so many specialists here today, and I want you guys to know you're part of the solution here. So Brad, would you talk a little bit about the program?
So it was Nebraska Total Care. So we were in Upside, and I see what Medicaid pays them for our patients. And I said, I want some of that money. So what we did is we negotiated with them. And by the way, Nebraska Total Care wants to get away from fee-for-service and wants everybody to do value-based care. And so what we have done is we've negotiated. So we have full risk contract with Nebraska Total Care for about 2,700 TANF patients, which is temporary assistance for needy families. So we're 100% responsible for their care. So we've got about a $14 million budget that Nebraska Total Care and us manage. We pay for every doctor's office visit, every ER claim, every pharmaceutical medication, every inpatient, every behavioral health. Anything that creates a charge comes out of that pot. And so our providers are incentivized to stop them from going to the ER, stop them from becoming an inpatient. Because what we do is with the amount of money that we get from our incentives, we don't budget it, where it's not part of our budget. We split that 50-50 with the providers and our staff. So we actually had to cap the providers because otherwise they're going to be making private practice money, and we can't have that. But our providers are capped, and so they are incentivized to keep the patients out of the hospital. So they go above and beyond calling the patient, having their nurses call the patient. One of the things we found, and you guys probably already know this, but with Medicaid patients, they are the highest utilizers of ER visits, and not every one of them, but the majority of them have a secondary diagnosis of depression. They are not there usually in the ER for the primary diagnosis of whatever illness they have at that time. They're there because they're lonely. So we work with companies like In Good Health. They call those highest risk patients once a month. And along with our MAs calling them, they get personalized attention. So that works out well, and it is keeping people out of the ER. We still have regulars, we still have those that go there weekly, but for the most part, they have now several opportunities to talk to one of our staff or get their questions answered. And so we don't get paid for a fee for service for those patients, those 10 patients. We get a capitated payment, so we get X amount of dollars, a very small amount of dollars per patient per month. And at the end of the year, whatever that shared savings is, there's about a 9-month lag to get all the claims data in. But out of that $14 million, let's say you save Nebraska Total Care $3 million. Or excuse me, let's say you save them $10 million. So now there is $4 million left that you share with that payer. And so they cut you a check for $2 million. That is a lot more than you would receive from them for the patient service revenue, especially Medicaid patients. And so it was a lot of angst doing it.
Why don't we start with that? Where did you start?
So we started by looking at the data. So you guys all have data. I would say the first place to start is talking with your payers on your high-risk patients. Talk to them, say, which of our patients cost you the most money, and what are you willing to do to help us decrease those costs? One of the things, so I'm going to throw this out there. I'm not an attorney, blah, blah, blah. But if anybody's going to enter into a value-based contract with a payer and you want someone to review it just to make sure you're not getting screwed over, I've seen lots of these. I've been screwed over. And so I'm willing to look at them for you at no charge and help you try to figure out, what should be here and what shouldn't be there. But that's where I would start. I would find out with your payers who's our highest cost patients, and then go back to the payer and say, how much is it worth to you if I can decrease that by 20%? That is where I would start.
Good. And then I think the second point was about building a longitudinal patient engagement program. So this is a lot of the programs he discussed. Would you mind just talking a little bit about what you guys did with the vegetables, cooking classes?
Yeah, so another thing we found, so Lincoln is the refugee capital of Lincoln. And so we get a lot of refugees. And one of the things that we were finding is that when refugees come to the city, and then someone else brings them groceries. Well, what Jane was finding is she would go in there, and a lot of the refugees, they were told this is a stove, this is a microwave, this is a refrigerator. They didn't know what any of that stuff was. So all the groceries that were being brought were sitting on the cupboard and rotting and going bad. And so one of the things that we were looking at is, okay, so why is this happening? Well, a lot of the stuff, a lot of the fruits and vegetables that we have, they're not familiar with, and they don't know how to cook. So we worked with the UNL Extension Office to have cooking classes. So all of our patients, a couple times a year, we'll do kind of a cooking class, and we'll show them. We used to work with Community Crops. They had a veggie van, and that was great because it was $25 that we would give our patients every week. Each week they would get $25 worth of veggies. Again, we used ACO money and stuff to help pay for that. And so that's been very good, and it's teaching those new families as well as low-income families. I was very poor. My dad was an alcoholic. He was a farm laborer. I didn't know how to cook broccoli or anything. We weren't experienced that. Kale, I still even wanted kale, but I know how to cook it. But a lot of people just have never been exposed to those fruits and vegetables and know how to use them correctly. So that's one of the things that when you look at data and when you look at, taking care of that patient holistically, those are types of things that you find. and don't be afraid to do something. I mean, a lot of us, it's easier to say that's someone else's problem or whatever, but just do it. And a lot of the times what you think is a lot of money, being a lot of money, it's a high value, low cost proposition, and you're doing a world of service for that patient.
Love it. So we have about 5 or 6 minutes left. And so I think when I, prior to joining this organization, when I thought of patient engagement, I thought about, okay, texting patients, messaging patients, patient portal, and like communicating with patients. But what I realized is this is patient engagement. This is actually helping the patient have the right tools, have the right knowledge, have the right coaching to be able to make a difference in their lifestyle and improve their health. And of course, that drives savings. They talked about $1 invested into primary care translates to $13 worth of savings. So, and again, I know I have a lot of different specialists in here, but I think it's really important for you guys to engage your primary care and say, how can I help? What kind of programs can we help provide? And so I know with the times we have, I think it's important to talk about, and since Brad hit a lot of these points already, I'll skim over these, but if you think about the definition of population health, this is really what we talked about earlier about managing a population. So there are really 2 health outcomes. There's either length of life or quality of life. And this all comes from the county health rankings model, how counties are ranked from their health. But they've really summed it up into 4 different health factors. Health behaviors being 30%, clinical care being 20%, socioeconomic factors 40%, physical environment 10%. And Brad gave some great examples about this already. But I think the main point is, even if we're providing the best clinical care, we're only impacting the health of that life only 20%. And so I think when it comes to patient engagement and how do we engage our patients, really the best way to engage them is the other 80%. And honestly, you're responsible for 100% if you are in a program similar to Brad. So I think it's really important to be able to understand some of these factors and how can you be able to identify and intervene in these needs. So and we'll kind of skim through this, but what can I do? Like, what are some practical ways to be able to take these baby steps and eventually move into to be able to jump off the deep end? So first off, as Brad mentioned, is understanding your patient population. If you know that your patients are maybe you have more diabetic patients in your community, or maybe more behavioral health needs, or whatever those might be, you have to know that, because that's going to help you establish and prioritize which programs you need to institute. Maybe this vegetable or cooking class doesn't make sense for you because maybe diabetes isn't as important. But I think if you understand your data, you're going to be able to prioritize there. And then as you see at the bottom, also understand your non-clinical needs. Maybe unemployment is really high in your community. Maybe you can host a job fair or get involved that way. There's a lot of opportunities for you guys to be able to get involved there. The groups that are doing what Brad's doing really well is being able to prioritize their patients by risk stratification. I won't get too much into this, but when I talk to groups in Florida, what I love what they're doing is they actually are much more granular. They all actually have 6 different stages. So Strat 6, they're calling or reaching out to or showing up at their house every day, every other day, whatever it might be. They're offering transportation to all appointments. They're doing a lot of things for this layer. And Strat 5, it might be every other day. Strat 4, it might be once a week, etc. So I think it's really important to understand this. The reason being, I think if you take anything away, is understanding if you had to divide your patients into 3 buckets, which ones are the most chronically ill, which ones are your rising risk patients, and which ones are your low risk. Because so I think when we think patient engagement and what we've been offering in that way for patient engagement, that's really what we've been offering, what we should continue to offer for your low risk patients. This is low touch. This is things like text, interacting with them, that type of way. But when there's a problem, they should know where to turn and not go to the hospital. And so I think that's the biggest point for this specific patient demographic. For the rising risk, this is that magenta cranberry color there. This is, I think, this is the low hanging fruit. These are patients who are or can be motivated to be able to make lifestyle changes if provided education and coaching and some accountability. So with that being said, this is where I would focus a lot of attention to. And obviously the patients that are most chronically ill, you guys are doing everything, all hands on deck to try to help these patients as it is. These are the frequent flyers. These are the patients you know so well. But I think that this rising risk patient population are the ones that are disenfranchised by healthcare system in general. And when something does happen, because they are on a health trajectory that could lead to that top 5%, if they continue down that road and they do end up needing to go have a health need, they're going to go to the hospital. I can promise you that. And that's just going back into that fee-for-service problem that we've discussed. But if they know that somebody's there, they know that they're engaging with their practice, with a physician, that's going to be the first place they turn when they move forward. And then, of course, as Brad alluded to, that's really where the biggest revenue driver is as well. So here are two programs that are really value-based care programs, but currently being paid in a fee-for-service world. So these are kind of what I consider low-hanging fruit. One being annual wellness visits. So whether you talk to Serpa out there or Alidate in the room next door, they'll preach this as well. So there's no copay to the patient. They can only be seen once every 12 months, but the reimbursement is $160 on average per patient per year. And then there's the chronic care management program. These are patients with 2 or more chronic illnesses, which already qualifies them for that rising risk patient panel. And then you reach out to them for 20 minutes a month and help them manage their chronic illness. They're getting that patient engagement that they need. And I think this is what's going to drive everything. I'll skip through this, but as you notice, if you look at annual wellness visit, it's really all focused on all those needs that Brad was just talking about. And one last thing for Bluestem specifically, here's the program that we were doing for him. About 775 patients are enrolled in the program that we try to reach out to every single month. But here, if you look on the right, these are the interventions, these are the follow-up. So if you can, whether you have a chronic care management program or you're just trying to reach out to patients and engage with them however possible, these are the outcomes that we hopefully can drive, things like new appointments. So the care navigators, as they're talking to the patient, they identify, wow, Dr. So-and-so wants to see you if your blood pressure is above this. I'll go ahead and schedule you next week. Or based on the escalation protocols, we need to see you today. But other protocols, we might just send you right to the hospital. So really, that's really important. Other screenings, medication compliance, this is a big one too.
That's just 1 month too.
This is just August. This is all in just August. So I think, and I know our time is up, but I think it's really important. This is patient engagement. It is being involved. It is finding needs. It is putting them in the right spot, helping them navigate what is the very complex and very costly healthcare system. So that is all we have today. I appreciate it. If you want to reach out to Brad, here is his email, my email as well. I also post patient success stories, posted on LinkedIn and also on a YouTube channel called Value Based Michael. But thank you guys for your time today. I really appreciate it. You guys are doing great work and just keep it up. Thank you.